Welcome to this series of neonatal occupational therapy webinars for enhanced level practitioners. My name is Deanna Gibbs. I'm the Director of Clinical Research for Neonates and Children at Barts Health NHS Trust, and I have 2 honorary academic appointments. This webinar is part of a programme which is a collaboration between the Royal College of Occupational Therapists and Health Education England, which is aimed to shape the future of the AHP workforce working in neonatal care across the United Kingdom, and is designed to be used by people working in all 4 nations. It is aimed at occupational therapists who are already working in neonatal care and an enhanced level of practice, and it's part of a wider blended learning programme that includes this series of webinars as well as an in-person workshop. So in this webinar, we're going back to basics and we're going to consider occupational therapy models of practice and their application in neonatal settings. Over the course of the session, we're going to briefly position the theory of occupation in the neonatal setting context. We'll briefly review some of the key theories around occupational performance. And then we're going to consider the application of 2 specific models, occupational adaptation and the person-environment occupation model, into the neonatal context. And finally, we'll apply the PEO model within a clinical case study. So the learning objectives of this webinar is that by the end, you'll be able to review the key models of occupation that underpin occupational therapy practice. You'll be able to analyse the applicability of 2 OT models to parent-infant co-occupations in the neonatal unit setting, and also to apply an occupational lens to a typical neonatal case example. So I thought it would be helpful to go back and start with the very basic definition of what we mean by occupation. And over time, various theorists, academics, and professional bodies have really thought about how we define what we mean by occupation. And that certainly has changed and evolved over time as well. But in essence, occupations are the ordinary and familiar things that people do every day. But when we drill down within that, we can see that they are much more complex than what that very simple definition may appear to mean. The activities that we engage in throughout our daily lives that fulfill our time, and they also give our life meaning, but they have contextual, temporal, psychological, social, symbolic, cultural, ethnic, and also spiritual dimensions. And occupations can therefore reflect the unique characteristics of a person, and to some degree, we can become defined or choose to be defined by the occupations in which we engage. I think one of the complicating factors when we think about how we use and define terms of occupation in our work in any particular clinical context is that over the last 30 or 40 years, there have been a multitude of terms which are used to describe the theories or philosophies that underpin what we do as occupational therapists. And you can see on this slide, we have going from basic occupation, from activity, more recently to words such as participation and engagement, looking at what happens with occupational deprivation or occupational imbalance, can mean that there can be a level of confusion in terms of what are we actually meaning when we're talking around theories of occupation or occupational performance. And so I think it's helpful for us to think about how clearly or overtly are we using models of occupation to underpin our clinical practice as occupational therapists. We know from our core training the importance and interplay on function and performance and participation that occupation has in terms of how they can contribute to our overall health and well-being. And we certainly understand the need to apply some of these theoretical frameworks to really support our best practice. However, that's sometimes quite difficult to see in day-to-day clinical practice in a variety of particular settings. Some of these barriers are very common and can really get in the way of how overtly people feel comfortable in using occupation-centred practice. Firstly, I think there can be a lack of understanding of the models. As we saw from the previous slide, the variation in terms, some of the subtleties and sophistication in thinking about the differences between some of the models can make it harder for people to really be clear about how they are using some of these theories to support their practice. I think we did go through a period of time where we lacked confidence as a profession to really advocate for the role that occupation has in promoting and maintaining health and well-being, particularly when we went through a time of working in a very biomedical and reductionist health society. I think as OT becomes more innovative and starts to work in newly emerging areas of clinical practice, there can be a period of tension when we think about how we apply some of these occupational theory-based models to our practice. And to some degree, that has been the case with neonatal settings as well, where we've really sort of, it's been the last 20 to 30 years that occupational therapy has been working in these settings. And as we also saw from the previous slide, the lack of consensus and consistency in how we use theoretical concepts can also cause confusion for practicing clinicians. And then I just briefly wanted to refer to frames of reference, because I think sometimes the notion about theoretical models and frames of reference can be used synonymously, that they are different. Frames of reference are defined as a series of compatible concepts which are derived from a theory and can guide a plan of action for what we actually then do in terms of assessment and intervention within specific OT domains. So examples of some common frames of reference which you have probably used include the biomechanical, sensory integration, and obviously in the neonatal setting, developmental care. But these all focus on underlying components which can be promoted to ultimately contribute to improved occupational performance. So we're going to do a very quick overview of some key occupational performance theories, and then we will look at two specific models in relation to how they can be applied in the neonatal setting. I would like to preface this by saying, although we're going to use two more applied in the case examples that we will look at later, neither I nor the Royal College of Occupational Therapists are necessarily advocating for the use of one specific model when you work with infants and families in this setting, but more to refresh your memory and understanding of perhaps some of the similarities and differences between the models, so that when you are choosing a model to overtly underpin your clinical practice, you're confident in your selection of doing so. The first model we're going to refer to is the model of human occupation, which was developed by Gary Kilhoffner originally in the 1980s based on the work of Mary Riley. And you can see here that his model has three personal components: volition, habituation, and performance skills or capabilities, and then thinking about the interaction of those within the environment. So Kilhoffner's model was really the first general model which focused on occupation, as theories prior to that had really been specific to physical rehabilitation. And it aimed to provide a framework to conceptualize how people both select, organize, and undertake their occupations. MOHO is a systems-based theory, and it proposes that occupational performance is a result of an interaction between three person factors: volition, habituation, and performance capacity, and the overall environment. And he defines that as social, cultural, and physical. The model proposes that any change in personal factor or the environment may elicit a behavioural change and facilitate new patterns of performance. And this is a very robust model that has been applied to many, many different settings. And as a result, many different assessment tools have been developed over the past 30 years, often grown out of a need for setting-specific measures. But some you may be familiar with or have used, such as MOHOST, OCARES, the AMPS, role checklist, etc. So the MOHO is supported by 5 key theoretical principles. The first of these, that occupational actions, thoughts, and emotions arise out of the interactions between these 3 person components and the environment. That a change in any aspect of those person components or the environment can also result in a change in how we think, how we feel about what we're doing and what we're actually doing. That our volition, habituation, and performance capacity are maintained and change through what we do and how we think and feel about what we do. A particular pattern of volition, habituation, and performance capacity is maintained as long as the underlying thoughts, feelings, and actions are able to be consistently repeated within a supportive environment. And finally, that change requires that novel thoughts, feelings and actions emerge and are sufficiently repeated in a supportive environment in order to coalesce into newly organised patterns. It could also be considered that MOHO centres on the processes of occupational adaptation, although the model does not state this overtly. But when a person engages in an occupation, it creates a sense of occupational identity and occupational competence, both of which are conceptualised as components of occupational adaptation. And all of this is occurring within the context of an environment that is shaped and serves to shape aspects of the process. The next model we're going to look at is the Canadian model of occupational performance and engagement. And if you have a look at the diagram here, particularly that on the left with the yellow triangle in the middle, the productivity blue circle and the environmental green circle, and we'll explain how that is represented in a moment. So the CMOPE aimed to make explicit the relationship between the person, the environment and occupation. And it's based on the assumptions that occupation, which is the domain of concern for us as occupational therapists, serves as the bridge to connect people with their environments. The model has these three main components, as we just saw: the person, environment and occupation. The person, which is depicted as that yellow triangle at the centre of the model, is portrayed as having three performance components: cognitive, affective, and physical, with spirituality as a core element. The model also depicts that the person then is embedded within the environment to indicate that everybody lives within a unique environmental context that has cultural, institutional, physical, and social elements, which affords that person occupational possibilities. And that occupation then is depicted as the bridge that connects the person with their environment, indicating that individuals act on their environment through their engagement in occupations. And the CMOPE identifies three specific occupational performance purposes: self-care, productivity, and leisure. The model proposes that it's the interaction between these three components that results in occupational performance, which they define as the ability of a person to perform occupations and daily engagements. And the CMOPE is the model, and certainly its earlier iterations as well, which really introduced the concept of enablement into occupational performance theory. So shifting from purely the outcome of the performance to the process of enabling. And for those of you who use the Canadian Occupational Performance Measure, or the COPM, this tool was developed in congruence with this particular theory. So moving then now to the Person, Environment, Occupational Performance, or PEOP model. This was developed by a group of American academics, originally published in the early 90s, and the most recent publication in 2015. And you can see here, like the previous models, we have elements of person, environment, occupation, and performance. So this model tries to focus on the intrinsic and extrinsic influences on an individual and how that influences the performance of their everyday occupations. And they talk about the fact that this model can be applied to individuals, but also to groups, organisations, and populations. Like the MOHO, it is a systems model. It recognises that the interaction of the person, environment, and occupational performance elements are dynamic, they're reciprocal, but also in terms of the tenets of occupational therapy practice, that the person has to be central to the caregiving, care planning, or intervention process. Because they determine that only the person, or family, or community, whichever the context is, will be able to determine which outcomes are the most important and necessary. The PEOP model is transactive in that it views everyday occupations as being affected by or affecting the individual and their context. The occupational performance is in the centre of the model, and it's emphasised as involving three specific components. So the characteristics of the person, and that includes their physiological, psychological, motor, sensory perceptual, cognitive or spiritual components, the features of the environment, and as you can see, we're getting both broader but more detailed in the specificity of which environments we're talking about. So in this model, they refer to cultural, social support, social determinants and social capital, the physical and natural environments, education and policy and assistive technology, and then occupations as characterised by activities, tasks or roles. So the model proposes that when people perform occupations, they also interact with their environment, resulting in reciprocal consequences. So a person's goals and intentions will influence their occupational performance. So very much harking back to that volitional aspect of Kiel-Hoffner's MOHO model. And the resulting action can both change the environment, but also the person's characteristics at the same time. But also that this interaction between the person and the environmental components may both positively or negatively influence occupational performance. When there is good person-environment fit in supporting the performance of valued occupation or participation in valued occupation, we therefore see success in occupational performance, which will eventually lead to promotion of participation and well-being. And the model identifies factors in the personal performance capabilities or constraints and what are the enablers and barriers in the environmental context, which are central to the occupational performance, which is the goal of the individual, which in then turn can lead you as an OT to develop with that person a realistic and sequenced intervention plan. And so the graphic representation of the model is intended to convey that occupational performance is not only determined by the nature of the activity, task or role that's being performed, but also by the characteristics of the person, the intrinsic factors and the environment, which are the extrinsic factors. And being minded that performance and participation are always going to occur within these two contexts and ultimately determine well-being and quality of life. I'm not going to go through this slide in detail, but just as an indicator of how detailed some of these models are becoming in terms of helping break down from a clinical reasoning perspective what we're specifically looking for in terms of person and environmental factors. This gives you an example of the various different considerations within the PEOP model. So we're now going to move on to looking at two particular theories and how they can be applied within the neonatal setting. So firstly, the model of occupational adaptation, and then the person-environment occupation model. So the occupational adaptation model aims to integrate the two main domains of occupation and adaptation for OTs. And it defines occupation as self-perceived, meaningful activities that require active participation and lead to a product. And I think, again, harking back to MOHO, we start to really see the importance of the volitional aspects in terms of what activities or occupations are perceived as meaningful or motivating for people to engage within. They define adaptation as a process through which a person and the occupational environment interact when a person is faced with an occupational challenge, which calls for an occupational response reflecting an experience of relative mastery. So there are 6 key theoretical principles which underpin the occupational adaptation model. The first of these is that we are occupational beings who have a desire to master our environment, and we manifest this through participation in occupations. That the environment in which we're conducting our occupation demands mastery from us, and these demands can either enable or restrict our successful participation in our activities. And our level of mastery and the environment's level of demand for mastery creates both occupational roles, but also demands and expectations of those roles, occupational challenges, and specific responses from us as individuals. To navigate this press for mastery, or to be able to acquire the type of occupational activities and roles that are meaningful, a person will go through a normative and developmental process of occupational adaptation. However, during participation in occupations within a specific environment, we may experience occupational performance breakdown. And when that occurs, we might respond adaptively or disadaptively to that breakdown in performance. So when we're thinking about this model from the context of being an occupational therapist, the most important role for us then is to think about how we can elicit and facilitate an adaptive response from the person. So that is to enable that person to participate in the occupations that are important to them, to facilitate the environment in such a way that it is enabling of their performance and participation in those occupations, and to use that person's engagement as a way to empower this adaptive process to occur. The authors propose that the greater the adaptive transitional needs, the greater the importance of the occupational adaptation process and the potential that this process has to be disrupted. And it places emphasis on the person's interaction within the natural setting for occupational performance. And again, like the others, really centralises the importance of placing the individual at the centre of goal setting, treatment planning and evaluation. So I just wanted to share briefly an example of how the occupational adaptation model has been applied to working specifically with parents in a neonatal setting. And if you wish to read more detail about this, the reference is included at the end. This model is actually applied specifically to parents because historically a lot of our work within the neonatal setting has been very infant focused, but more recently has evolved to a more family focus, where we're very interested in terms of the occupational capabilities of both the infant and the parent. But I think it's sometimes helpful for us to take a step back and actually think about the parent as a client themselves in the neonatal setting, in terms of their preparedness and readiness, and perhaps some of the facilitation barriers to their occupational engagement before we introduce the concept of co-occupations with their baby. So just very briefly, what this model is aiming to demonstrate is the process of occupational adaptation that parents experience as they have a baby who's admitted to a neonatal unit. So you can see there's a continuum or a process that occurs. So from the moment during pregnancy, where they are anticipating being a parent, thinking about the tasks, roles, occupations, activities that will encompass becoming a parent to a new baby. And then this significant moment of occupational disruption where they deliver a preterm or a high-risk infant that requires that baby to be admitted to a neonatal unit. And some of the occupational disruption that occurs as a result of that. So primarily that's relinquishing their imagined or anticipated role of a parent. So not necessarily being able to do any of those occupations or activities or roles that they perceived during pregnancy that are meaningful, and there's the subsequent impact that has on their sense of self-efficacy. They may also be juggling other roles and responsibilities outside of their time within the unit. So we have issues around occupational imbalance. And then in terms of the environmental aspect, it's a very new, potentially very technological environment where they are trying to practice these new occupational roles of being a parent, but there's a complete mismatch between their capabilities and the environmental demands for mastery, creating this feeling of vulnerability and powerlessness. But over time, we see a process of occupational adaptation emerging as they learn to adapt to the neonatal unit environment. And we can really see this clearly in terms of the work that parents put into reclaiming an alternative parental role. So that is elements around being able to be close to their baby, being able to engage in activities that they see as meaningful, as being a parent, or nurturing as being a parent to their baby. Part of that obviously has environmental elements, so being able to navigate the environmental boundaries, both the physical and the social boundaries, in terms of able to feel close to a baby that has a high amount of technical support needs, but also developing partnerships with the staff environment in terms of navigating facilitative and inhibitive relationships, and also the position of the baby in this. So coming to recognise that this baby is being part of their family and what capabilities their baby brings to this emerging relationship. And so this process of adapting to parenting continues, certainly as the baby developmentally matures. The parents are able to start to participate and engage in more and more of the activities that they associated with parenting prior to their NICU admission. But we also need to be mindful that at the time of discharge, that's not the end point for these families, that becoming the parent of a preterm infant results in quite a new reality for them as they discharge from the neonatal unit and beyond, whether that's because they have a high-risk infant who is being followed up for neurodevelopmental sequelae, but also just in terms of the impact on them and their parent, on their relationship with their baby because of this traumatic experience that they have both experienced. So we can think about how occupational adaptation plays out in that we see that transitions occur as parents seek ways to reclaim an alternative parental role. And certainly for us as occupational therapists, we can have a key role in supporting that occupational adaptation as parents prepare for this new reality of parenting a preterm infant. We can be mindful that adaptation is a normative process, but given the complexity of the occupational transitions that follow the birth of a preterm or high-risk infant, we need to think as OTs about the means by which we're supporting parents to create and maintain this new sense of parent identity, who they are as a parent, how it's important for them and what it means for them to engage in those activities. Townsend highlights that participation is a central feature of enablement, and it's through participation in occupation that people generate and express visions of possibility to resolve occupational challenges. So if we think about this in the early days of a neonatal unit admission, what we're supporting parents to do is to generate ideas about who they can be as a parent, even if that's very different to what they anticipated that being examples of, so that they can start to create this space and create the opportunities to think about being a parent to this baby in this scenario and what skills and capabilities we can support that parent to develop as they work through this process of participation. And so focusing on these transitions gives us a framework to think about how we're supporting parents in our occupational therapy practice. And I think going back to some of the other models that we've looked at, it also really highlights the resonance or the importance of supporting parent-identified, meaningful occupational engagement in terms of how that serves to construct their occupational identity. The second model we're going to look at in terms of its application to the neonatal setting is the person, environment, occupation model. And so this was published work initially in the mid-90s by a group in Canada. So the PEO model considers human functioning and learning as a product of complex person, environment, occupation interactions. So a lot of similarities with some of the models we have already looked at. I think one of the things for me that differs with this model is it conceptualizes that the person and his or her environments and occupations are interacting, but that there's this dynamic temporal element in terms of how these occupation, environment, person interactions and transactions can change and morph over time. This group of authors defined occupations as clusters of activities in which we all engage in order to meet our intrinsic needs for self-maintenance, expression, and fulfillment, and that we then carry out occupations within the context of our individual roles and capabilities and across multiple environments. The three domains of person, environment, occupation are independent and affected by each other. In this model, occupational performance is defined as the outcome of the transaction between the person, the environment, and the occupation, and the extent of the congruence of these transactions is represented by the degree of overlap between the three spheres of the model. The higher the level of congruence, the quality of occupational performance is increased, and vice versa. The poorer the level of congruence, the more impact on occupational performance we will see. And as I mentioned, the PEO model does take a lifespan perspective, so recognises that the three domains and occupational performance will change over time. In terms of how the elements are defined within this model, so in the person domain, we're talking about role, self-concept, cultural background, personality, health, cognition, physical performance, and sensory capabilities. And like some of the other models, person is broader than the individual, but could include the family, communities, agencies, governments, so on and so forth. Within the environmental domain, we're talking about the physical, cultural, institutional, social, and socio-economic environment. And then, as I mentioned, occupation are those groups of tasks that a person engages in order to meet his or her self-maintenance, expression, and fulfillment. So what we can see in this model is if we explore the transactions that occur between each aspect of the model, so the person occupation, the occupation environment, and the person environment relationships, we can use this to think about our clinical reasoning in terms of what strategies might we want to consider to serve to overcome any barriers that we notice that exist in order to support optimal occupational performance. And just as a note to refer back to the CMOPE, it was developed subsequently to this PEO model, and it's nice to consider them both together because it has certainly served to further advance understanding of the transactive nature of the domains within the PEO model, and also introduce the notion of occupational engagement rather than purely performance. So we're going to think now about how we apply the PEO to neonatal practice. And I think the two key things to think about working within the neonatal setting is how we think about the complexities of these transactional relationships between the PEO domains in order to guide our clinical reasoning around what our approach to assessment and intervention will be. And then, as we saw with the occupational adaptation model, we want to consider the temporal aspects of the model. How is this going to influence the PEO domains for the baby and their parents from the time we have a first contact with them, as they move through the various levels of acuity in the neonatal unit, and then beyond discharge as well. So let's do that in terms of thinking about a case study. So in this scenario, you're going to arrive on the unit for your first contact with baby Sophia and her parents, Nita and John. Sophia was born at 28 plus 2 weeks gestation. She's now 29 weeks postmenstrual age. Sophia is Nita and John's first child. In terms of her clinical presentation, she's receiving respiratory support via CPAP. She's being nursed in an incubator. She has a PDA, which she's receiving treatment for. She's having supplementary feedings via an NG tube. Her mother is being supported to express breast milk from day one. She's also having regular episodes of apnea and bradycardias, which are noted particularly during caregiving. In terms of some of the background for her parents, her mother works in administration. She went unexpectedly into labour at work and had an emergency C-section delivery due to Sophia's distress. John, her father, is now on 2 weeks parental leave before he'll need to return to his work as a mechanic. They have limited extended family nearby. Nita's family live abroad and John's family lives several hours distant from them. They live about 45 to 60 minutes from the hospital, depending on public transport, which they use and will be using to get to the hospital. Nita has obviously remained in hospital post C-section recovery, and they've been attending the unit every day within her physical activity tolerance, but she's due to be discharged today. And they have not yet had an opportunity to hold Sophia. So what we're going to very briefly do is consider what are the PEO transactions that we might need to be thinking about as we work together with this family to promote parent-infant co-occupations. So we're going to look at the person environment, occupation environment, and person occupation transactions. Now, these aren't exhaustive, but just a quick thinking around some of the key elements in each of them. So in terms of the person environment transactions, so on the left, we're going to think about Sophia. What's the impact of the environment on her, and particularly on her neurobehavioral regulation? So what is the impact of having the CPAP mask, the NG tube in, the various lines in? What's happening in her immediate physical environment in terms of the incubator? What type of postural support does she have in place? How well is that serving her in terms of keeping her regulation stable? What is the impact of the sensory environment on Sophia? What is she hearing? What is some of the tactile input from the bedding and the equipment around her? And then obviously, what is the impact on her in terms of her parental separation from her parents? Some of the person environment transactions we might need to be mindful of when we're working with Nita and John is obviously the geographical distance from the hospital, and there'll be a funding implication in terms of their public transport costs every day. What is the local policy in terms of how the times that parents can be present? Are there times that they can't be present? What will that implication have for when John returns to work? What's the environmental culture, social culture of the unit like in terms of how supportive of the staff in enabling parent participation in caregiving? Further to the social environment, what's the communication patterns like between parents and staff? Are they generally facilitative? Are they occasionally inhibitive? What might that mean in terms of supporting occupational performance? And then for both parents, there's the ability, available seating to be able to be comfortable and present at their daughter's bedside, but particularly for Nita in terms of her post-C-section recovery. So a range of different specific things that we would need to consider both for Sophia as well as her parents in terms of the person-environment transactions and on occupational performance. If we think then about what are some of the occupation environment transactions that might be occurring. So for Sophia, obviously she has a range of different environmental elements which will be impacting on her performance in occupation. So primary to those is the ongoing medical interventions and equipment that are required for her respiratory support, her cardiovascular status, her temperature and nutritional stability. But also when we're thinking about some specific occupations that we are thinking about in terms of her general caregiving, particularly those that provide close nurturing opportunities for her parents as early co-occupational engagement. We also need to think about the availability of staff within the environment to promote performance of those occupations, such as skin-to-skin transfers. For her parents, they might see the environment as presenting quite significant physical and emotional barriers to engaging in parenting occupations. That could be due to the presence of the equipment, physically getting in the way, but also being a perceived emotional barrier. So not, for example, not being able to see their baby's face, or the incubator being a very physical barrier as a reminder of their separation from their baby. And again, similarly, what equipment availability is there to promote participation in co-occupation? So are there comfortable recliner chairs for parents to be able to engage in skin-to-skin for longer periods if the baby tolerates it? What presence is there for breast pumping equipment? Is it in the space? Is it in the baby's space? Does Nita need to leave the baby's bedside in order to express milk? So on and so forth. And then finally, we can consider some of the person-occupation transactions. So if we think about Sophia, how we're actually going to manage her fragility, particularly her apneic and bradycardic episodes during caregiving. So we're going to need to be thinking about what individualised support we are going to need to give based on her neurobehavioural cues. We're going to need to be mindful of the choice of which co-occupations we might focus on initially based on her status and developmental readiness, and actually be talking with her parents about building up that slowly so that we don't overwhelm Sophia's own emerging capabilities. But as a process of that, we might also then think about what are some alternative co-occupational activities that Sophia can engage with her parents that don't interrupt or impact on her status, but can still be considered as moments of connection and achievement for them all. And then from her parents' perspective, we might be mindful to think about their level of confidence in how they manage or respond to her fragile status or changes in her autonomic status during caregiving, their confidence in reading her cues, the availability that they have for opportunities for participation in meaningful parenting occupations. So can we work with the staff, particularly when perhaps John is back at work, or Nita's presences might be determined by public transport times and so on and so forth, that activities that are very meaningful then can actually wait until the parents are able to be present. We might need to think from some of the psychosocial support elements about managing parental fear in terms of engaging in specific occupations with their baby because of their fear of harming her because of how fragile she is perceived to be. And then individually for the parents, we also need to be mindful about Nita's continual physical recovery post-surgery, and also John's ability to be present once he's returned to work so that he also has opportunities for meaningful engagement in the care of his daughter. So once you've sort of used the PEO model to really think about what all of these transactions might be impacting and how they might be playing out in a particular clinical scenario, What you will then do is actually think about what you want to do to assess the current occupational performance of Sophia and her parents. So based on all of those elements, what is your assessment approach going to be? From that, you'll then develop OT goals, and these can be threefold. You are going to probably have some infant occupation focus goals, so goals that are specific to Sophia, to think about her promoting her performance of some of her early occupations, such as sleep and rest, her early opportunities for eating, her opportunities for engaging in interaction and relationships with her parents based on her stability. You may also have some parent occupation focused goals, so things that are very specific that the parents wish to do to feel that they have a meaningful and engaged way in caring for their baby. And then obviously you'll have goals which are supporting parent-infant participation in occupations that they perform together. And then from that, you'll then be able to develop your intervention plan that support goal attainment and enable occupational performance for Sophia, Nita, and John. So in summary, what we've hoped to share with you in this webinar is that there are many relevant models which focus on occupational performance, which can be used to underpin your neonatal practice. I think the important thing is to increase your comfort and confidence in explaining the relevance of why, as OTs, we are focused on occupations and co-occupations for infants and parents in the neonatal setting, and that we use this as our core OT knowledge to promote the added value that we bring as a member of the multidisciplinary team. What is the value of focusing on an occupation approach for both infants and parents and the family together in terms of delivering some of the neonatal principles around family integrated care, supporting the health and well-being and psychological impacts of a neonatal admission on parents, and also promoting and optimising the neurodevelopmental outcomes of infants. So as a part of this webinar, you have the opportunity to do some structured reflection and provide feedback for us. You may find this short 5-minute reflection tool can be useful to capture your learning from today and take forward with the other webinars before you attend the in-person workshop. And you can click on the link in the resources to take you to the tool. We'd also very much welcome your feedback on this webinar and the overall program to help us develop the program further. And you can link to the feedback form on this link here on the page. And finally, in terms of further resources and sources of support, I would very much direct you to the now newly published second edition of the Occupational Therapy in Neonatal Services and Early Intervention Practice Guideline developed by the Royal College of Occupational Therapists, which is available on the RCOT webpage. It has a lot of information that sort of talks in more detail about how some of the elements around intervention and assessment that you would do as a neonatal occupational therapist and the evidence for those, which you can then align with your overall approach from your theoretical model. And if you haven't accessed it already, the HEE also has an e-learning for health program aimed at foundation level neonatal occupational therapists, which you might also wish to review. I've also put together at the end here a list of all the references that I have included. So if anything was particularly of interest to you and you want to read in more detail around any of the models or any of the information presented, you will be able to do so. So thank you very much for your time.